Hello everyone, my name is Lakshya Kaur. I am an internal medicine resident PGY3. Today I'll be presenting a case of primary amyloidosis which was localized to just the breast. The reason why we chose this case was because localized amyloidosis is a rare disease. Usually it's systemic. Amyloidosis usually involves multiple organs. So our goal was to explore the causes of localized amyloidosis, whether it progresses to systemic disease. And we had an incidental finding of invasive ductal cell carcinoma, and we were concerned and wanted to study whether it involves malignancies. So in our case, we had a 72-year-old female who presented to the office because she had a right breast mass. She had a lumpectomy. Biopsy showed lymphocyte aggregates, multinucleated giant cells. Then patient came back to the office in a year because she had recurrent growth, and this time she was afraid and she wanted bilateral mastectomy. That was performed, and the pathology of the left breast showed extensive amyloidosis. Right breast showed extensive amyloidosis, but it also picked up invasive ductal cell carcinoma, which was ER/PR positive but was HER2 negative. So we also did a axillary lymph node to see if the cancer has spread or not. That also showed extensive amyloidosis, but both left breast and the lymph node were negative for any sort of malignancy. So now our goal was what was causing the amyloidosis. So we did the thorough workup for understanding are there any lymphoproliferative disorders or malignancies. So she had urine electrophoresis, serum electrophoresis. That didn't show multiple myeloma. Cardiac MRI and abdominal fat pad biopsy was also unremarkable. So we went ahead, and I think on the serum electrophoresis, yes, we did pick up IgG lambda with the protein, M protein levels were just 1.1 gram, but the kappa to lambda ratio was actually above 0. So the biopsy was kind of pointing towards lambda. The serum electrophoresis was pointing towards lambda, but the ratio was pointing towards that kappa is in higher amount. So that was where we were concerned whether MGUS was the contributing factor to her localized amyloidosis. And in this case, usually the treatment for localized amyloidosis is just lumpectomy in breast. But this disease is so rare, and in our patient there was extensive amyloidosis in the left breast and the lymph node. So we decided to side on the side of caution and start her on systemic chemotherapy, which involved daratumumab, cyclophosphamide, bortezomib, and dexamethasone for 6 months, and then just daratumumab for 18 months. So when you were reviewing literature, we studied that localized primary amyloidosis is actually a relatively rare phenomenon, and it's actually seen in postmenopausal women during surveillance. On MRI or ultrasound, you'll see a mass presentation could involve a painless, palpable mass. There's so many case studies just based on how to distinguish based on radiographic studies whether it's amyloidosis or that mass is malignancy. So that's also interesting. But the definitive diagnosis is histopathology exams, staining techniques, and biopsy. And the treatment for localized is just usually they recommend lumpectomy or mastectomy. But like I said, this is such a rare phenomenon. There's so much literature and kind of ambiguity. So you kind of look at case to case to see and risk stratify a patient. Also, there have been, in the literature, they've reported underlying breast malignancies too. You'll see invasive ductal cell. There are other actually malignancies like hematological, extranodal marginal B-cell lymphomas, plasma lymphoproliferative disorder. So from this case, although localized is benign, but it's extremely important to kind of monitor and do a thorough workup on this patient to see do they have underlying amyloidosis, and also monitor them for malignancy, because that can change the management and prevent the disease from progressing. Thank you for your time.